Hi, I'm Dr. Jeff Habert. I'm a family physician in North Toronto, assistant professor at the University of Toronto, very involved in educational initiatives, including multiple national guidelines, and I'm joined today by my good friend Dr. Anil Gupta.
Hi, Jeff. I'm Dr. Anil Gupta, as Jeff said. I'm a family physician and a researcher. I've done research and been published as the lead author in the New England Journal of Medicine, JAMA, Canadian Family Practice Journal, and most recently, Canadian Primary Care Today.
All right, welcome. We're going to have fun today. We're actually going to talk today about iron and iron deficiency. And first of all, I want to distinguish iron deficiency from iron deficiency anemia. We know iron is mandatory in our bodies to maintain multiple physiologic functions, and iron deficiency is when the stores are low. So we're going to talk about ferritin. Normal ferritin would be over 30 or 40. So when ferritin's low, it's called iron deficiency. When hemoglobin becomes low, so under 130 in a male, under 120 in a female, we call that iron deficiency anemia. So there are differences. The other thing to note is a third of the world actually has iron deficiency anemia. In Canada, we say like over 2.5 million Canadians have iron deficiency, not necessarily iron deficiency anemia, and about a quarter of those have iron deficiency anemia. So, Anil, what causes iron deficiency anemia?
So many causes of iron deficiency anemia. We can have poor absorption, such as post-bariatric surgery, or with PPI use. It can be related to blood loss, such as menstrual blood loss or GI blood loss. It can be at times where we need more iron in our body, such as during pregnancy or during growth phases. And it can also be with low iron intake, such as with vegan or vegetarian diets or individuals with low socioeconomic status. Unfortunately, it is being shown that despite low household income being one of the greatest associations with low iron, it is being shown that those individuals have their ferritin checked less often. So we should do more ferritins, especially in those high-risk groups. It is important to note, like Jeff said, that we should treat iron deficiency even if there is not anemia. Iron deficiency alone can cause symptoms such as fatigue, dizziness, mood changes, leg cramps, and cognitive impairment, especially in children.
You know, I think it's so important on what you've said is we want to detect this early. And the standard test is actually a serum ferritin, not a serum iron, actually a serum ferritin, which measures the iron stores in the body. And as I mentioned, we're looking for levels over 30 or 40. The one problem with serum ferritin is it's an acute phase reactant. So if you're unwell, if you're sick, if you have an inflammatory disorder, serum ferritin can be falsely elevated. But generally, it is the best test we have. And as Anil just mentioned, we want to catch iron deficiency before it becomes iron deficiency anemia. And as we talked about all the causes, we need to look. So common causes in our world in primary care would be menstrual loss or inadequate nutrition intake. So these high-risk patients need to be screened so that we can treat the iron deficiency before they become anemic.
Now, in Canada, we have many oral iron formulations available. We have ferrous fumarate, which is 300 milligrams, but 100 milligrams of elemental iron. We have ferrous sulfate, which is 60 milligrams, ferrous gluconate, 30 milligrams, and then a newer kit on the block, especially newer in Canada, ferrous ascorbate, which is 100 milligrams with built-in vitamin C. We also have other formulations such as polysaccharide and heme irons, and more formulations are becoming available. Now, in medicine, how do we make choices for our patients? Well, usually it's based on evidence or research, but unfortunately there are very few studies comparing oral iron supplements.
You know, the problem is it's confusing for primary care because there's certainly a difference in efficacy, absorption, and tolerability with all these iron preparations. But in addition, we have to look jurisdiction to jurisdiction in terms of cost, coverage, and other factors which we have to look at in primary care every day.
Yeah, and Jeff, I agree with you. And guidelines don't seem to help us, because if we look at guidelines through Canada, there are guidelines from British Columbia, from Alberta, from Hamilton, Ontario, and there's a midwife statement. None of these guidelines recommend one iron over another based on efficacy, but only based on cost and tolerability. So it's hard for us primary care docs to make a decision. Now, this could be because all of those studies I mentioned are older studies, usually published in smaller medical journals, and may not be well known.
And I think that adds to the confusion, as you just mentioned. And so we're in Ontario, so looking at jurisdiction in Ontario, we tend to use a lot of ferrous fumarate because it's covered by our formulary. And I mean, I've seen studies suggesting that the absorption of ferrous fumarate's not great. I think what's exciting is I know you've just done a clinical trial which will help us bring light to the differences in absorption. So tell me a bit about your trial.
Okay, Jeff, so we did a randomized open label trial, actually the largest comparative study ever done comparing oral iron supplements. It was done at 2 family practices offices, one Toronto, which was my site, and another Peel region site by Dr. Vishwas Kinney. We enrolled 111 patients, adults, with confirmed iron deficiency anemia and followed them for 12 weeks. This study is published in Canadian Primary Care Journal. We debated really long and hard about which iron supplements to choose, but in the end we chose 3. Ferrous fumarate, EBMfer was the brand name with 100 milligrams of elemental iron. Ferrous Ascorbate, EBMfer was the brand name with 100 milligrams of elemental iron and built-in vitamin C, and a polysaccharide iron which was Ferromax with 150 milligrams of elemental iron. Hemoglobin and ferritin were performed at baseline and once again at 12 weeks. The patients received the iron supplements at no cost. We funded this study. Jeff, the difference in hemoglobin and ferritin were quite significant, with the ferrous salts clearly outperforming the polysaccharide. The hemoglobin rose by 17 points with the ferrous ascorbate, 11.6 with the ferrous fumarate, and 3.56 with the polysaccharide. Similarly, the ferritin rose by 23.5 with the ferrous ascorbate formulation, 19.2 with the ferrous fumarate, and 3.2 with the polysaccharide.
I mean, that difference is huge, Anil, and I bet if you look at primary care physicians in Ontario who are generally using fumarate, and many may have not even heard of ferrous ascorbate, that difference is huge, and it's important for us to educate primary care that all irons aren't created equal.
Yeah, absolutely, Jeff. So I think the results are quite dramatic. Clearly the ferrous salts were more effective, and especially the ferrous ascorbate, the EBMfer. Interestingly, the compliance rate was higher with the polysaccharide iron at about 89% versus both ferrous salts that were at 79%. But despite this increased compliance with the polysaccharide, the ferrous salts were clearly more effective.
You think this had anything to do with side effects? What about the side effects?
So the side effect profile was, as I'm going to tell you now, so 13 out of 34 patients that completed the study had side effects, or reported side effects, I should say, with the ferrous fumarate. The numbers are 8 out of 35 for the ferrous ascorbate group and 6 out of 35 for the polysaccharide group. And the most common side effects in all the arms were constipation and bloating. Now, Jeff, I've given you the results of our study, again, the biggest study ever done in the world. So now that you have these results,
I mean, it's so difficult because I like the data that I've seen with ferrous ascorbate, and I've seen data in the past also. But I think in primary care, the reality is we have to take cost into consideration. And we know that fumarate is much less expensive than other salts, traditional irons, 20% of the cost in some cases. But I think when you see a trial like yours, it's so important to look at the cost benefit of using ferrous ascorbate in getting that efficacy and tolerability so that our patients' hemoglobin and ferritin, their iron stores, will rise.
Jeff, I agree with you. And my approach after the study was finished has become the same as yours. So I still use ferrous fumarate when cost is a factor, but if cost is not a factor, then my go-to now is Ferrous Ascorbate, that EBMfer. Now, another reason that I may switch from ferrous fumarate to the EBMfer is when tolerability is an issue. As my study showed, there was better tolerability with the EBMfer, the Ferrous Ascorbate. I also no longer use polysaccharide irons in my practice. So I also do iron infusions in my practice, and I get referrals from other doctors. I have noticed that many of these patients coming in for infusions are on a polysaccharide iron, mainly Ferromax. As I have shown, the polysaccharide irons seem to be less efficacious. So by us choosing a less efficacious product for our patients, not only do the symptoms not improve, however, we're leading to more invasive interventions such as intravenous iron or perhaps even blood transfusions. Therefore, it is very important to choose an efficacious iron.
I think what you said is just so important, and we didn't talk a lot about iron infusions, and they certainly have a place in those that have severe iron deficiency. It's very, very effective, but you're right, we're traditionally using a lot of polysaccharides and ferrous fumarate because of cost, but I think we need to look at cost, benefit, and efficacy. So why do you think Ferrous Ascorbate or EBMfer was more effective in your study? Is it the vitamin C?
So, in this study, we did recommend ferrous fumarate to be taken with vitamin C or orange juice or on an empty stomach to improve absorption. However, despite this, there was still more efficacy in the Ferrous Ascorbate, which was the EBMfer. Perhaps this is because the vitamin C is built in, and so therefore individuals don't need to do that extra step of taking the vitamin C separately. It also appears that the polysaccharide iron was less efficacious because it is not well absorbed.
Okay, Neil, tell me, what were the limitations of the study, and are there any biases in this study?
So, one of the limitations of the study is the study was performed at two sites. So one was my site in Toronto and another site in the Peel region with Dr. Vishwas Kinney. So the results may not be generalizable through Canada. However, the results are compatible with previous studies showing ferrous salts are more efficacious. Now, another possible limitation is that we did not include all iron formulations that are available. So a larger study should be done, including other formulations such as heme irons and perhaps other newer formulations. Now, so far as biases go, this was a pet project of mine that I've been wanting to do for a few years. I, along with my study coordinator, Amisha Gandhi, wrote the protocol, got ethics approval, and we funded the study. And we actually conduct the study along with the help of that other doctor, Dr. Vishwas Kinney. And so I funded this study. There was no external involvement, no industry funding at all.
Okay, thank you, Anil. I mean, so interesting and I think so practical for primary care. So my takeaway points from this are iron deficiency and iron deficiency are extremely common. We should be treating iron deficiency before our patients develop anemia. We know that once daily or in many cases alternate day dosing are quite effective, and they'll improve tolerability and improve adherence. We know that there seems to be a very significant difference in the efficacy / absorption of these products, as you've shown in your study and the other studies. I mean, your study looked at 3 very commonly used irons in Ontario and Canada, and Ferrous Ascorbate certainly performed the best, and I think we need to consider that if the patient can afford it. And then, go back, like you said, for me, if the patient cannot afford Ferrous Ascorbate, I'll use ferrous fumarate, but my go-to tends to be Ferrous Ascorbate in this case, because we've seen the trials. Before yours, there were other trials, as you mentioned, and hopefully in time we may see coverage for Ferrous Ascorbate, and hopefully guidelines will be updated to show how important iron absorption is. So thank you very much. This was quite enlightening and I think quite practical for our family practice and primary care colleagues. Thanks a lot, Anil.
Thanks, everyone. Thanks, Jeff.